Hello and welcome. You are listening to the Be Part of Research podcast. I'm Turi King, and today I'm talking to Dr. Manish Parikh, Associate Clinical Professor in Infectious Diseases at the University of Leicester. So Manish, tell me about your research. What is it about?
Hi, Tori. So over the last 10 years or so, I've been working with migrant communities, mainly in Leicester, but also outside of Leicester. And my area of interest is trying to identify how we can understand individuals who have infections and try and diagnose them early so that we can provide them with treatment and make sure that they're better.
I know that in this country, and particularly in Leicester, the migrant population, or the number of people who've been born overseas, is somewhere between sort of 15 and 30%. So this is a real issue, isn't it, around equality access to healthcare?
Absolutely. In overall in the UK, we think just under 15% of individuals are born overseas. In Leicester, it's at least 35%, perhaps up to 40%. And individuals will come from many parts of the world, and they will come for many reasons, often to escape strife, war, but also for economic reasons. And they come with different life stories.
So how do these services work? How do the people access them?
So what we've tried to do, so if I take you back kind of 10 years or so, much of what we've done or we have done and I have done has been born out of what I've seen in my clinical practice and seeing patients. And I remember when I was training in medicine, I would see young patients, often from the Indian subcontinent or sub-Saharan Africa, and they'd come in with quite severe tuberculosis and often quite sick. And it got me thinking at that time that, this wasn't right, 20, 30-year-olds becoming so unwell that they were in hospital for weeks on end sometimes. So I thought, well, is there a way that we could, offer testing for an inactive form of TB, give them treatment before it becomes more severe, so that people then don't go on to become unwell enough to require hospital admission. And then we did some work over the last kind of 5 to 10 years, first when I was doing my PhD, and then more later when I came back to Leicester. And what we've basically tried to do is develop systems where people who are coming to GP surgeries are offered early testing. We don't wait till they become sick. We offer them proactive early testing for a range of key infections. And those key infections might be tuberculosis, hepatitis, and also HIV. And the reason for that is if we can identify them early, we can just get on and start treating them if they require it. But it also has an additional benefit. It means that people aren't potentially transmitting to other individuals. And also, we're building trust. We're building trust with communities whose voices haven't always been heard over the last many years. And by proactively going out to them and saying, look, this is a service set up for you, they then feel that actually they have ownership of a system, and then they take part in the screening program. And we've seen in Leicester certainly really good uptake of the program.
So what were the attitudes when it was first set up, and has that changed through time, or?
Yeah, so I think in terms of the migrant community, the NHS is a great thing, absolutely brilliant, and it is set up to deliver great care for individuals. But it also has systems which, if you look at it objectively, might not be the easiest for a consumer or a patient. So if we think about someone who's arriving into the country and we want to test them for, say, tuberculosis, they'd go and get their test for TB, then they'd go and see a specialist. Then they'd go all the way back to their GP, who'd then test them for hepatitis, and then they'd have another visit to the hospital. So lots of stops. And these are young, economically active people. They don't have time to go to lots of hospital visits. The better way is you test everyone in one go, and then they come and see one specialist. In our case, it's me. So I run the clinic, and it means that I can see them for the range of infections. They like it. They don't have to go to lots of different doctors and nurses. But also what it does mean in terms of when we set it up, the migrant community, I think, bought into it. But also who did buy into it were the local GPs and public health physicians, because it does need a change in mindset. We often have systems set up in healthcare which are often quite old, and changing things takes time. So there was But what I have to say, locally, there wasn't really that much resistance, which was really good, and they were really positive. And I think they are now seeing the benefits of that locally.
So, what are the benefits of community based screening?
So we know that if we're going to try and identify infections or other medical conditions, we need to try and take that to where the individuals are. And most healthcare is not delivered in hospitals. Most of it's delivered out in the community. And by community, I don't mean just GP surgeries. I think more broadly, I think pharmacies, community pharmacies, and other settings. So by proactively going out into the community, firstly, we're making that step out of our comfort zone of being in hospitals. Many of us work in hospital settings. The positive attitude from the GPs to say, actually, yeah, that's quite good, has over time, we set this up in 2016, Terry. So, it's become almost like routine practice now. And we're probably one of the only places in the country, I'd say probably in Europe, that now routinely offer this through primary care when people are coming in to be, as a new patient. But I think what GPs locally and the system saw was that, it's a really relatively small cost for quite a big gain. And we talk about, in the NHS about what the term is cost effectiveness. Is it worth doing the testing? Because is it good value for money for the NHS? But actually, for me, more important than that actually is that these are communities where equity is important, and these are groups who haven't really been heard, who've had their voices heard. So by proactively working with them and building relationships, we bring together the patient or the migrant community. They're not always patients, of course, GPs, public health, and the hospital to bring together. And actually, it's been a real pleasure working with them over the last few years.
Describe the research to me. Is it surveys? Is it talking to people? Is it visiting a clinic? What does it look like for those taking part?
Yeah, so much of the work that we do is what I would call kind of health services research. So there's 2 or 3 elements to it. The first element is that we develop or integrate a new program into a public health program. So this would be combined testing. So as they come through the testing through their GP, we will analyze over time, what's the pickup rate? How many people are we identifying with the different infections? Where are they coming from? So that's one aspect of it, to kind of just get an idea of what the actual level of infection is, because that information isn't available. Second aspect is what we would call qualitative work, so interviews and focus groups. So we're having kind of discussions with both migrants, but also the healthcare providers, so GPs, hospital physicians, nurses, and asking them, is it good to move away from just doing a single point of testing, like TB testing, and doing this sort of combined program, and trying to understand what that program should look like. Is it good? Is it bad? Is it worth doing, etc.? And then the third aspect that we will do is work out the cost effectiveness. The reason being, there is a TB program, which is funded by the government, by NHS England. My aim is to look at what we do locally and go back to the government and say, actually, we've done this, and it's cost effective now to move away from just doing TB testing, but perhaps moving forward to doing other tests, etc. And it's really important that this is what we've tried to do is move research out of hospitals, out of universities, and really very much into the community. And I think that's really where you get a lot more input. And actually, as a sort of byproduct to that, we started to try and understand with those groups that we're working with, had they ever had the experience of doing research before coming to speak to us or doing our work? And what was clear, Thierry, was that actually they'd never really had the opportunity. A lot of these guys want to be involved in research. They've got a lot to say. They've got really good viewpoints, and they can change what we're doing, but we just have to go and find them. And you may hear this term, hard to reach. And I just find that term completely wrong. I think they are very much, the communities are all around us. We just have to go and work with them. And once we work with them, the program evolved, and was very much developed around that. And the educational materials couldn't have been developed without them.
I really love this integrated approach that you're using. That's really, really clever way of doing it.
Yeah, I think, well, it's partly because my my vision when I came back from London was to create a sort of network across the whole city where people would be able to access care wherever they. So some people will go straight to A&E, right? They bypass the GP straight into A&E, and they get testing there because that's there. Some people go standard through the GP. Some go to pharmacies, schools, colleges. But the next step would be factories or employers. There's absolutely no reason that we can't do that, and it's been shown for diabetes testing that you can deliver it in employment settings like factories, etc. So that would be the next area to kind of think through going forward.
So have you had any surprises whilst you've been doing this engagement work then?
Surprises in the sense that, well, no, in the sense that not from the migrant community. I think what I have found is that I think what I was really a bit taken aback by was the fact that people were willing to kind of break down those barriers that have always been in place in healthcare and see the value of this sort of combined program. I thought it was going to be a much more difficult ask than it was. It's interesting because we deliver it now locally, but if you speak to colleagues in other cities, they just haven't quite been able to kind of break those barriers. And I think that's our fault, as we're not able to understand that it's not about us really, it's about the community, and it's about society and making things better for them. So I think that's been the real surprise. The other issue will be, of course, making things sustainable. But at the moment, all the evidence we have is that this has become kind of very routine for GPs, and people see it as a real benefit. So that's good.
So what would you recommend to people who want to work to break down those barriers? What approaches would you recommend?
Yeah, I think, well, there's a number of things. I think the first thing to think about is who are you trying to deliver care for, and why are you delivering care? So what is the objective? And the objective in this case was engaging with communities who haven't really got the opportunity to have care delivered to them. And if we can do that, how do we do that? Do we set up our classic systems of multiple visits to multiple different systems, and at each point, Turi, you'll get a drop off because people are like, I'm not going to bother. I've got work to get to, etc. So you think about what's your objective, what's the vision, and to do that, who do you need to bring together to deliver that? And that's not just healthcare providers. Actually, it's also the patients or the migrant community, and making sure that they have input into the program, because by working with them, you'll very quickly understand where the resistance in the community might be, or ways around that. And I think if we can do that, you're able to move things forward. Leicester is quite specific in its way that it's been set up, and we're lucky that we have a single provider, single GPs who are quite engaged, and in other settings they don't always have that. So I think I'm not naive. We have a specific position that we have locally, but I think others can learn from it to kind of redevelop their services.
I think that's really interesting what you say there. So what generally are the barriers from the community side? What stopped them from getting involved?
Yeah, so we know that historically migrants, ethnic minorities haven't taken part in research. I think there's no surprise in the sense that data is well understood. The reasons for not taking part is less well understood, I think it's fair to say, because I think the engagement that we have done as academics, as clinical researchers, has been not always the best. I think COVID has highlighted some of those ethnic disparities, and the involvement in research has been mixed, I would say. And I think the barriers are multifold. I think, for some individuals, that it's about trust. It's about building trust. I might well be seen as being part of the system, and trying to then deliver research. There's always a little bit perhaps of distrust about the program and what you're trying to do. The second thing, I guess, that's quite relevant here is that these are often young individuals. Research is quite low down, right? I mean, they're here for very specific reasons, earn a livelihood and live comfortably. And research doesn't mean that much to them at that point until you engage with them for them to see the benefit. And that's where I think we've had that gap. We've not always engaged with them. But I also think that some of it's around knowledge. They will come from settings where research has never been delivered to them or has been delivered in ways which perhaps isn't correct. So there is that sort of little bit of a barrier. So I think you have to, work to do that. And I think this is what we've done over the last kind of 5-7 years, really, locally, is build relationships, build experience of working with individuals from different, disparate and diverse migrant groups, so that they then have trust in you and what you're trying to achieve, so that they then take part in research. And I think that will have benefits for going forward, particularly, for COVID for now. But then going forward, I see this much more holistically. Once I've developed a program for infection, you then think about diabetes, cardiovascular disease, vaccination, etc., etc. So you can then start to develop programs much more broadly.
So, what for you has been the key success of this research?
Well, for me, the key success has not really been the program. Actually, it's been much more about engaging communities and healthcare providers who historically wouldn't have been involved in this sort of work. GPs who are busy, many of them aren't research active, busy working in inner city Leicester or in East Leicester, seeing lots of patients, but coming together to kind of see the value of trying to put together a program. But also then the real benefit for me has been the engagement that we now have with those communities, and the fact that we know that we can have made some steps, and not massive steps, but some small steps to trying to understand their health concerns and how we might try and objectively deliver better healthcare for them. For me, that's one of the real benefits. And going forward, I hope it forms a sort of foundation for further work, really.
So that takes us very nicely into, so what are your hopes for the future for this work?
So for me, I think the work has reached a bit of a sort of a fork in the road, because I can see the real value of combined testing. I think the GPs can, I think the migrant community can, and the patients. We're going to do the full analysis because it's been sort of held up by COVID. So that will tell us how many people we've picked up and what the costs and the cost value for money for the government is. But for me, the real question is, should we be doing combined testing? So the next step would be perhaps to develop what we would call a much more targeted combined testing program. By that I mean, we know that let's take this as an example. You come from country A, we've tested 1,000 people from country A, but we've only picked up disease TB in one of them. Actually, maybe we shouldn't be testing everyone for TB. So the next thing would be to kind of use artificial intelligence and work out develop algorithms for testing. What takes me slightly away from that is that when I speak to migrants in the community, they like combined testing. They don't want to have a targeted program necessarily. They prefer as you said, the MOT approach. And I think GPs like the MOT approach because it gives them reassurance that nothing has been missed. And as medics and as healthcare professionals, uncertainty is something that we have to deal with. But uncertainty, if you missed quite something potentially quite serious, might be something a step too far. I think the other area that we do really want to work at with, not just in terms of the program, is about developing some of the issues around public health messaging. And I'll come on to COVID just briefly here because this isn't about COVID, and I think we've learned from COVID that some of the public health messaging, particularly at the start of the pandemic, wasn't really very good, particularly for some of the ethnic minority communities. And I think it was a real shame. I think some of the stuff that we'd learned here could have translated very quickly into national programs. I think we are getting there now, but going forward, I think some of that learning is something that I want to kind of focus on.
So, what one thing would you like people listening to this podcast to remember?
So, I guess the one thing I'd like everyone to remember here is that all of us, wherever we're from, and whatever experiences we've had, whether we're from the UK or from overseas, we've all had life experiences, and we're all, in the end, living in the UK, we should all be offered equal healthcare and equity of healthcare. and not just healthcare, but also access to healthcare research. So I think one thing I really would want us to try and do is make sure that we engage with communities so that that equity is seen across the board and it's not just for certain groups.
Well, Manish, I think the NIHR are very lucky to have you working on this stuff. Thank you very much for listening. If you'd like to listen to more podcasts or find out how to take part in research, visit www.bepartofresearch.ac.uk.